start that. And then we have some nurse visitors, by the way, RNs who are getting their BSN, just graduating from an RN program. So the names you don't recognize, that's who they are.
Okay, good. So they haven't been before in my prior presentations, I would
No,
assume so. Also, they're welcome to ask many questions about anything that we say or anything else, because I'm going to assume that we have talked about a lot of things before in this topic.
Yeah, that's great.
So if something doesn't make sense, feel free to ask, and we'll digress a little bit if we have to. And, I actually don't have a lot of remarks prepared. I have a few remarks to make prepared, but otherwise, it's looking forward to a conversation. So,
Dr. Lopez, this is Mary Ann Williams.
hi, Mary.
You won't
Mary.
recognize my name, but I attended one of your, the Zoom presentations. And on that one, you suggested that I attend the UC Mini Medical School online. I just wanted to thank you for that. I'm not a medical person. That was so great. I just wanted to thank you for it. I'm looking forward to the next one. I don't know that I understood everything, but I think I learned a lot. And love that the guy from the vet school also did one of the presentations. Oddly enough, I found that very interesting too.
That is great. Thank you. Thank you.
Thank you for suggesting it.
Yeah, you're just reminding me of my days in medical school where I would go to the first lecture and I just had no idea what was going on. And it was until the third time that they will be presenting something that I actually really got it. So repetition is very important to recollection. So
right. Well, and then I think the PowerPoints and the graphics and the videos were so good that it helped someone with a non-medical background understand. And one of the doctors, I can't remember who she was, I think she was the first one, she had just such a great storytelling to it of these guys are fighting these guys. I mean, she made it sound like a medieval war of germs, and so it helps you remember when these things are brought to life like that. So anyway, thank you again. It was great.
Yeah, thank you for sharing. And if when you learn that the next classes are coming, maybe you can share that with the rest of the group. See if others want
it. The mini medical always tends to be in February. It's been every February for the last 10 plus years. So
yeah, plus they recorded, and I still have links. I don't know if they're still up on their website, but if anyone's interested and wanted to check that, they how you clean up the recordings and the videos and then put them on a website. They did that with all of them, so that could be useful for those who might be interested.
Was this during the last year's COVID that you?
Yes. It was the last mini medical school, and Linda's probably right. It was probably February. It went on for 6 weeks, I believe, every Saturday morning. It was pretty structured. It was great though. It really was. And it may still be on the website. And I didn't go on and look at them again. I thought I would, but I just haven't had time. So I don't know if they left them up, but sometimes, websites leave things on there forever.
Yeah.
And sign up for people that are interested is usually in November. If they're going to go in person, they have a limited number, the capacity of the room. If they go online, we're able to be open to a lot more people, but you still need to sign up.
Right.
And it was free too, obviously, right?
Yeah.
Free. It was free and very well done, I thought.
Okay, Javier, we're on.
Okay, well, well, thank you for having me again. And my first duty is to apologize for Dr. Shakari's inability to join us today. We have planned for her and I to do a presentation today about cardiac and breast cancer, but she had a a commitment that came to her from the chair of her department to make a presentation to the department. And so she had to attend to that. And she's currently giving a talk, to which I know she's very nervous and worked really hard for. So I'm hoping she does well, and hopefully we'll be able to be back next month to do this, to do the presentation together. The good news is we were going to be excited about the presentation next month, because the grant that we wrote together, she and I wrote a grant, which is the origin of the presentation. That grant just got funded this morning. So you're the first ones to hear about it. So we're really excited that we'll next year or two, we'll be working on prevention for women with, not specifically with breast cancer, although we'll talk about that next time, but prevention for women who are seeking to prevent breast cancer. They're doing their preventive measures for breast cancer. So it's how to combine, what we're doing is how to combine cardiovascular prevention with breast cancer prevention. So more about that next time. But what I thought I would do today is just, we've throughout the pandemic, we have had days where we just review data, review the latest information before the vaccines and then after vaccines. And so we kind of have been having these conversations, monitoring what's going on. And Linda and I thought this may be a good moment to do a kind of a check-in on what's going on again and kind of have a conversation. I hear that there may be opportunities for you guys to maybe return to physical encounters over at the gym at Sac State, and so that's exciting. That's very exciting, and physical social interaction is super powerful. And we talked before about how to overcome loneliness and other things that can definitely affect our cardiovascular system. And so I personally cannot wait until we can get together again. But I think there's some changes in the behavior of this pandemic, and there are things on the news happening every day, and things are once again changing rapidly, at least in the conversation at this point, which may create questions and ideas, maybe some of concern, others of relief. And so I thought we could have a brief kind of conversation about that and answer questions and see whether, should we be relieved or should we be concerned at this moment? And at the end of the hour, let's try to answer that question. Should we be relieved or concerned about what's happening in the present? So to get that conversation rolling, I do have a few slides that just to share a little bit of available data at this moment, and then we can use that as a trampoline to start the conversation. So I'm going to go ahead and share my screen. Any questions so far about what we're going to do? Okay. So there are two tables on this slide. On the left is a screenshot from my phone. And so at the very beginning of the pandemic, I kind of selected a few cities that I was interested in and that I would keep track of throughout the pandemic. And there are, some of them are obvious and others are not so obvious why I picked them, but most of them I have some sort of personal connection to them, family members or others, or some of them are because of projects that I know of or I'm aware of that I like to be able to keep track. It's not that important which one are the cities that are listed here. What they're listing here is the daily number, the daily cases per 100,000 people positive for COVID. And then in the column to the right is the 14-day change. So when they look at the average over 14 days, they look and see whether these numbers are changing, in what direction they're going. And what's striking about this is it's going up everywhere. So over the last several months, since we started vaccinating people, this is kind of a mix, kind of like the Dow Jones of stock market. It's mixed. Some were up and some percentages were down, but currently everything is up. So if these were stocks, you'll be trying to buy stocks, I guess. I don't know much about the stock market, but this will be a moment you will pay attention because everything is concordantly going up, every city. And this spans, Puerto Rico, California, Florida, so it's all over the country, Texas. And so this is the moment where I say, it's time to think about this again. What's going on with this? So let's look at the graph on the right now. And the graph on the right, which I've shown before, but I know there's a few people here that haven't been with us before, so I'll walk through this again. The top panel is cases as a function of time. So going from February 2020, which is presumably when the pandemic began in the United States, to the present. So this is out here, July, whatever we're today. And so this is the number, the frequency of cases, and this is what people talk about waves. And actually, let me see if I can get my pen here. So this is the first wave right there. This is the second wave. This is kind of a commercial waves here melting together. And then this is right around here. I got my vaccine in January, which would have been probably right here. So from this moment on into the present is the vaccine.
Well, you're good with that.
So you can see that the downtrend. So we were going. This pandemic was just accelerating. To this point, there's some dips and downs depending on what happened in the news cycle and how many people were masking at the time. And masking and distancing was all we had here. Whether people were staying home or not, whether people were putting masks or not, washing their hands. But right around here at the peak of it, thank God we got, the vaccines came online and we started vaccinating people, and then boom, a plunge. And so when you look here at where we are today, in terms of cases, roughly my line is tough to draw a straight line. But we're cases wise, we're kind of where we were in April of 2020 at the very beginning of the pandemic. So we've been really, really bad. This is really bad up here. This is the peak of the pandemic. And this is the reason I say it's bad. Down here is the death. This is the rates of death. And you can see there was a lot of death here in relation to so little cases, because we didn't know how to take care of this illness. We were just beginning to understand. And then we got a little better, here. So you see there are more cases, but not as much death. But here, boom, it exploded again. It probably spread out and more widely throughout populations. And again, we had a huge amount of death. Now we're here, kind of the same place we were, but look at where we are from death. We're really much death. And the reason for that, even though we have the same numbers of cases, is because of the vaccines. So if you're vaccinated and you were to have a case of COVID, you have a much milder case and very unlikely, very, very unlikely, you will die from it. In fact, it's very unlikely you'll end up in an ICU. It's very unlikely you even end up in the hospital. Do we hear cases on the news of people who got their vaccine, got sick, and went to the hospital and or actually died? Yes, there are a few cases. That's what's called a breakthrough. And no one ever expected that there will not be breakthrough. So it was always expected, just not what we most commonly talked about, but it was always expected. Every vaccine has breakthrough for the most part, especially in these highly communicable and highly variable viruses. There's always, some breakthrough. But the reality is that we are in such a better place. Even when you look at the number of cases, which are similar to where they were in April 20, we are mortality-wise such a better place than we've been at any moment in this pandemic. So I am optimistic. I think the vaccines are working. The vaccines have worked and are working for us as a population across the United States. And I think this data is pretty convincing that this is going to still continue to be the strongest, most amazing success story of humankind in terms of preventing worldwide disease like this. There's nothing in history like this. This is, kind of as a scientist, this is an amazing moment for humanity when we recognize the nature of this. And historians in the future will probably be much more eloquent that I can be about that. But that sounds great as an academic person. So what about real life? What about what we do every day? And I think that's probably what we ought to spend a little more time chatting today. So let's get closer to home. This is California now, not the United States. And we kind of missed the first hump of this pandemic here in California. So there wasn't much there. But we got the first wave, and then we got this, the torrential wave that we got, right after Christmas, Thanksgiving, Christmas, New Year, if you remember. And here's the curve of death that goes along with that in California. And vaccines come on, boom, no cases, and mortality drops out. So, I mean, this is the success story in California. And when you look at the other states where they have had the magnitude of vaccinations, this is how it looks pretty much across the board. Now, what about Yolo County? Very close to home. Here's the waves again. Somewhat of a low mortality. We got spare of this. LA got that, we didn't. We got really lucky in Yolo County. And we got a little bit in Sacramento. That peak, lots of cases, that mortality is there. But in Yolo County, we got really lucky with it. So that's kind of in the neighborhood where we are, kind of what's happening around us. So I am any questions so far?
Dr. Lopez, what I'm
Yes.
seeing on the news is that this sudden surge and the hospitals, being filled up and are people who have not been vaccinated. Do you find that to be the case? I don't know.
That is
what I see
that
on
is the case. That is absolutely the case. The numbers are somewhere fluctuating between 96 and 97%, depending where you look. There may be somewhere in the country where it's 85%. The people in the hospital today are people that are not vaccinated. But it is the non-vaccinated, right? So the 80 to 90% of people in the hospital today are the non-vaccinated people, not people with vaccines. And the data fluctuates a little bit depending who you listen to, and it changes because every day there's a new report or a new publication or something. So the number, this is what I mean, we are in the wave. We are not historically looking at this once it's happened. We're looking at it as it happens. But all the sources of data that I looked at, when you look at large enough populations, we're looking at about 96 to 97% of people in the hospital are people who are unvaccinated. I'm sorry.
And then where do you stand on, for those of us who have been vaccinated with the two, in my case, Moderna, do you feel, and some of us being a little older, maybe more vulnerable, is a booster recommended in your opinion?
I am going to ask you to hold that question for later.
Okay.
When we get into Q&A, let's talk about the booster and what we know. I want to call attention to one or two more features on these graphs. And so once we get done understanding the numbers that are of what's happening, then we'll come back about boosters and masks and discuss behaviors and what should we not consider to do.
Okay, thank you.
What I want to call attention is right here. So even though I'm so excited about that drop, I want you to pay attention to this here. Look at that line. And so unless something happens, this is the fear, is the what's coming. So now I'm doing the hardest things there's ever been, which is to predict the future. But if you look again, and I'm going to erase my line so you see what I'm looking at here. So I'm going to draw that again to call attention. See this here, so it was low. We were really, really low here for a couple of months. And then something happened, something changed. And trust me, it's not that we started going out to restaurants, or it's not that you forgot your mask at home when you went to the grocery store. That's not what happened. But something drastically happened, and you see now how this is kind of going up like that. Okay. So now it hasn't got higher. This is, I'm taking Yolo County as an example. It hasn't really got higher, but you can see this in Sacramento as well. Here's the same thing in Sacramento. You see that? Everybody see that? You see it in California, by the way. Here it is, that tail. So, you know, and I told you LA got the grunt of this death mortality issue. So they're freaking out. They're like, no, in LA, we're gonna start masking again because they don't want to come back here. They see this and they don't want to go back there. They've seen the future and they're seeing it again in front of them and they're concerned. Now, when you look here, even though the cases are going up, notice that in Yolo County, the mortality is 0 or near 0. I think there was one case on the news that made a lot of noise, but it's clearly a lot less than it was at the beginning and clear a lot less than it was at the peak of it. You know, people are not dying, even though there's more cases. That is the effect of two things. One, if you're vaccinated, you're not dying. The other one is that if a lot of the people who are getting that are not vaccinated by demographics are starting to be kind of the younger people. Those of us that are more health conscious and those of us that pay attention to the risk factors that we've talked in this group many times have made an effort, you know, in proportions. I'm talking in proportions. Have made the effort to get vaccinated, so they're not, you know, they're not so liable to die anymore from this. But so the people getting this who are vaccinated tend to be a little healthier, tend to be a little younger. And so they, by the nature of this pandemic, are not dying as often. And you see that also here. This is kind of the death curve, looks kind of flat down here. And it's pretty low, it's much lower than where it's been. So again, despite the fact that there are more cases, there's no, other than the illness, which has been mostly described now as a cold, mild flu scenario rather than the much more severe acute infection that we were discussing last year. These are the good news. This is the effect of the vaccine working again. So I wanted to kind of make that notation because when people talk about what's happening now, there's a distinction to cases versus actual severity of the case, and which the most extreme of the severity obviously is death, mortality. So this is what's generating a lot of the talk and chatter about things. Go ahead.
I'm curious because this doesn't tell the story of what percentage of the population this is. And Yolo County has, I think, about 200,000 people and Sacramento 1.5 million. So I'm not surprised to see this kind of variation, but I'd be curious to see it as a percentage of the population. And also the bias for me for Yolo County, and I live in Sacramento, is that the university is there. And I think people are more aware of the issues than maybe all the people in Sacramento.
Yeah, so that's a great question. So a great point. I mean, depending on the population, what's the society around the people you live? So if you live in a poor neighborhood, if you live in a crime-ridden place, if you live in a place where education and access to healthcare is not available, this curve is probably worse. Yolo County, the university, Davis, if you think of it that way, we're not, you know, in general, better access to care. I mean, where have you heard better than Yolo County and the Davis area where we have surveillance testing and vaccination programs? And I mean, this area has been a model for the success of how to contain, how to get the community involved and how to contain such an epidemic. It's not true in many other places. So it does vary because of the local population and varies by many of the social determinants of health and access and education and other factors. So let me see what I have on my next slide. My next slide is about the variance. And let's see, what do I have? So I had another slide because it's, I don't have it here, but one of the other places I'm tracking is in Florida. And Florida has a slightly different dynamics than here. And I don't have the graph of Florida. I'm sorry. I think I'm tracking Orlando because that's where my sister lives. And so they have the same uptick in cases, and they also have an uptick on death, which is very different to this. We are seeing flat or downward on the death. They are seeing uptick on death as well. And the other thing that I noted is that they stopped reporting death. In Florida, they just don't report death anymore. So we're no longer getting data on the mortality in Florida because they're not making the data accessible. So it's really interesting now how, you know, different communities deal with this, and some communities, you know, don't want to know, don't want to make it public of what's happening in their neighborhood. We're in California, whether you think it's good or bad, the data is widely available, and we have the ability to together kind of look at it and digest it in these conversations. So then let me shift gears a little bit to variants. And so this is a table, this is from the CDC, and I'm happy to share the link. This is all public information, by the way, nothing here not publicly available. This is a table from the CDC keeping track of the variants. And I think if I remember correctly, and I think I have it on the next slide, this is the Delta variant that everybody is concerned at this moment. And I think this is the Alpha, although maybe I'm not so sure about this. But in the next table, let's verify that this number is Alpha. I'm pretty sure this is Delta. And this just shows per state kind of the fraction as of a couple of weeks ago when the data was presented. So in California, we're 56% of our variants were already Delta as of 2 weeks ago or so. Missouri, 90%. And Missouri right now is one of the hot spots for cases as well as mortality. So it's kind of a, these are kind of the same in here. You start seeing a ratio factor. So as this goes up, this one has to come down, and this is how the conversation is Delta is becoming the predominant. So there are different patterns across the country in different cities, or actually states. But they're kind of all in the same direction, if you will. It's kind of on the upward for the most part on all of these. So this is how the variant transition looks like. And so, yeah, so the Alpha, this is the B117 is the Alpha. Let's see, is that correct? Yeah, there it is. It's the Alpha. The Alpha means the first one. So that was the first variant that gave us all the trouble on the back. And so this is April 2021. And this is a sum of 100%. So the contribution of any one color is the different variants noted here. And you can notice that the Alpha was the largest contribution. And now in July, just 2.5 months, Alpha has become a minority. And who started as almost nothing down here has become now the biggest one, which is the Delta. So this is kind of how in real time, the fraction of the variants have changed out in the population. And so what we know about Delta variant, let me mention Beta, because Beta has got some news. Beta was the one in South Africa, and Beta down here is, I think, here, there's Beta. And so here it is, here it is. It really has become a minor factor. It's almost inconsequential in the United States. So that basically stay away from the United States, but Delta clearly spread out here. Why is Delta, how is Delta different to Alpha and that to account for this? And so it's still being developed, it's still being trying to understood. It is, the data is patchy and not yet conclusive. But the pattern that we're seeing is that their patients that have the Delta variant have a lot more virus in their body. And so remember that getting infected is the result of how much you get. And so I recently heard someone trying to explain this in the following way. If you go outside and there's a light shower going on and you pull out your umbrella, you don't get wet. If you go outside and there's a hurricane blowing, it doesn't matter if you have an umbrella, you're going to get soaked. So with Delta, it's like having the hurricane pouring on you when it comes to virus. It's just lots and lots of virus. The virus seems to be able to replicate at large numbers in the body. So this is how large numbers of virus in the body of a person become such a transmissible thing. The fact that it goes from person to person is related to the amount of virus that moves in the air or kind of gets in your hand. So I'm almost sure that every one of us in this group has been in front of COVID and has touched it and it's likely breathed it. But it's probably such a slight amount that it did not affect you. Now with Delta, the problem is when you're in front of the same person as a year ago, you were in the same scenario where you were exposed a year ago. And now if that person has Delta, that person has a lot more virus. So then there's a lot more chance now, probability-wise, there's a greater chance that enough of that virus can sit in your body and then get you sick. And so what fights against the number of virus is the distance. So the farther away you're from somebody, the more you can fight the number of virus. If you have a mask, you fight the number of virus. So when you wear a mask and somebody's in front of you that has virus, you probably still get a couple of droplets of virus in you, but because the mask keeps the number so low, it doesn't really infect you. And that's the way it always happened with every virus and every disease. Your body's always fighting the battle of how much exposure did you get and how little. And some people, their fighting mechanisms are a little stronger, so they can tolerate more exposure. And other people, their bodies are a little weaker, and so they can't tolerate as much exposure, and they tend to get sicker earlier or easier. So that's dynamics that are applied to every virus and every infection. And so with Delta, what happens is people tend to have a lot more virus. So that's why it becomes more infectious. We don't know yet whether it's more severe, and that is conflicting at this point, whether it's more severe or not. And I'm not convinced. I think if it was clearly more severe, a more virulent virus, we probably would have known that by now. So even if it historically turns out to be a more virulent virus, it may not be for very much. It may be just so little that it's really hard to still tell. So it's not clearly more virulent. It's not clearly less virulent. It's kind of unclear. But it is the fact that there is remarkable more amount of virus on people when they get it. So it replicates faster or easier, whatever it is. I don't know. I personally don't know. There may be experts that do know why it replicates and there's more in it. But the fact is that there is more in people, and that's how it spreads easier across. Any questions about the variants?
I'm kind of curious just about the testing protocol. So you get sick, you come in the hospital, they draw your blood, and then where do they get all these statistics?
Yeah.
It's mind-boggling. But
so this does not come from the blood. It comes from the nasal swabs or the saliva. And Davis, we're used to the saliva thing, but in many other places in the country, they still do it in nasal swabs. And so when they run a test that it says, positive for COVID, then they take that sample and then they follow it up with a second test, which then does what's called sequencing, because you have to know every base pair of the DNA of the virus. You have to measure all the A's and the C's and the T's and the G's to be able to figure out the variants. A variant means that there may be an A or a T that is, that is switched. It's maybe just a single one or two base pairs in the DNA that are different. The test that they do to see whether you have COVID or not can capture all of the variants. That test just say yes or no, you have virus, but it doesn't say which variant it is. They have to send the sample, and so they have to send the sample to the health department, and then the health department process that usually in a core lab for that. In here, if you look here, they say total available sequences. So it's a surveillance program. They don't do it on everyone. They just take small number samples from all the different places that they submit. And so the monitoring sample for California was 4,231 of viruses that they got. So in Florida, they monitor this data is based on 2,600. So it's clearly a very small sample in comparison to the number of people who have actual tested positive. But these are samples that are sent usually to core labs in the health department from that are monitoring the patterns of transmission across the population.
Yes, Dr. Lopez.
Yes.
Okay. So I've listened to what you have said. I watch the news, and I get the feeling that I've got to take care of myself the way I did when this started. This whole thing started. That's the way I'm feeling. I talk to different people, and it seems like everybody feels that you vaccinated, it's okay, we can get together. I was invited to a get together. I decided not to go, and I got pictures of it. There were more than 30 people there, and no one was wearing masks. So you don't know who was vaccinated. You don't ask questions. Friends ask, why don't you come over? You're vaccinated. We don't have to wear a mask. There's just so much around that sometimes it's hard. And so I just kind of decided, you know what, I'm just going to go back to not exposing myself as much. And I don't know, what do you think about this?
Yeah, no, this is this is why this is hard, is because the way I see it, it was this has been the system of public health control of coronavirus in the United States have been taken to the level of the honor system. It's an honor system. And in the honor system that we have proposed, which by the way, we've never done this before. We've never put a public health matter in the United States that I'm aware of in an honor system. Usually the public health institutions do the testing, do the surveillance, do the monitoring, and we then find people where they are with their disease and we quarantine when it's bad disease. Think about smallpox, tuberculosis, all these very communicable diseases. There are programs that were built to contain and not allow the spread into the general population, in which people were screened, evaluated, found, and told, you have this disease, and society expected them to, as part of the societal contribution, to participate on the control of the virus or the infection, whatever it is. Tuberculosis is not a virus, it's a bacterial infection. So in this pandemic, we said it's on the honor system. You decide yourself whether whether you want to mask, whether you want to wash your hands, whether you want to vaccinate, whether you're going to tell anyone whether you have it. So there are guidelines. The guidelines are be on mask when you are among people who are vaccinated. But how do we know that? It's an honor system. So then how confident you are becomes proportional to how confident you are to the honor system, to how truthful everyone is about what they're doing. And the answer is we don't know that. We're not going to know very clearly how not only truthful, and I don't mean that they're deceiving purposely, but just educated enough to even understand the basis of what's happening. And then make judgments and make adjust behaviors based on true scientific understanding. And the answer is we don't. It's confusing. It's based on an honor system. So what I'm going to say now is all personal opinion at this point. And I told Linda I was going to make sure I'll disclaim my personal opinions, so not to be confused with medical advice or scientific knowledge. So I think it's premature, in my opinion, to assume that everyone in the grocery store or everyone at the family parties or work parties and gatherings is vaccinated and not carrying virus in such a way that someone else can get infected. And this works in different ways. This is a problem at different levels. One is, the other person that's not vaccinated in that group may likely get sick or could get sick. You yourself, as a vaccinated person, may have virus, a very small amount in you, and you don't even know it because you're protected, and you may be the harbor of that. The other thing is that the more people are not only unvaccinated and exchanging virus with each other, the more opportunity we're giving to the virus to develop more variants. And we are already paying the price of that, which has already happened last year. The virus spread throughout the world in so many ways until vaccines were available. And this is how all the variants we have today came about. And as long as we don't contain the replication of virus, more variants will come. And so this yo-yo effect is likely going to be with us for as long as we don't have full, I mean 100% vaccination. There will always be some variant out there in the making. And so there's uncertainty. So I think it comes back to personally, once you understand the factors. So what are the factors? Let me list the factors for you to take in consideration. What is going to protect you from having any of the variants we know today? Well, distance. The farther you're away from somebody, the more virus that person needs to have to get to you from person to person. So distance is one factor. Second factor is a barrier. So putting a mask of some sort, which minimizes the amount of aerosol that comes out of your mouth. Third thing we have is hand washing, and don't forget hand washing. Hands is still a media in which we can spread virus around. So hand washing is very important. And the fourth one is the vaccine. Those are our tools. Those are the 4 tools we have. And so if everyone was following all 4 of those, likely we would quench most of the cases. I won't say all because I don't know that. No one knows that, whether we will ever get to all, but most of it will definitely get quenched. And I show you already some of the data of how even people, when they even with quitting to use masks and start going to the restaurants, the case numbers kept dropping because of how powerful on that equation is the vaccines. The vaccines are super powerful. And so if everybody was vaccinated, I think we can then relax the others and still be safe. What we don't know today is the contribution of all of these to each other. And so then you have to start asking questions like you're saying, my family gathering, I don't know that everybody is vaccinated. No one is masked. No one was keeping distance, so the pictures probably everybody was like this, and we're all doing selfies and stuff. So distance wasn't there. So you basically abolish all 4 components to protect yourself. And so if you conclude that that's not safe, I would agree with you. You just have, because it's in the honor system, we all have to start making the judgments for all these 4 factors in the group that you're going to go and join in. So, and I think that's what creates all the uncertainty of the present.
Dr. Lopez, they say that they're testing all the athletes and I guess the newspaper people and so on in Japan. How are they getting the results so fast? Because apparently, from what the news media says, that the athletes are getting tested every day. So how can they get all these tests through? What do they ramp up their laboratories or what? I mean, just curious.
Yeah, I'm sure they ramped up their laboratories. I mean, Davis did that. Davis has an ability to test the entire city of Davis every night. So, and in fact, they do it. If the entire city of Davis were to show up, they don't all show up at the same time. But if they all were to show up to get tested in the Davis sites, every one of those samples get done within 24 hours. You get results the next day, whether it's 10 a.m. or it's 2 p.m., depending how many they got the night before. But everyone gets a result the next day. So it is a process of surveillance. It's not, they don't test you and then hold you somewhere. I think there's actually people flying in have to actually wait for 3 or 4 days. And part of that is a little bit of a quarantine mixed with some testing. And then they can go into the Olympic Village. But then the daily is not intended to keep you from doing your daily thing. It's a surveillance. You keep testing every day, and if at any moment any test comes positive, what they do is they track, they find you, and then they track who you were in contact with, or which building you were in, or which place you were in, and then they go looking for others in that area for contact tracing. So it's kind of a surveillance contact tracing program. It's not a program to keep people in real time from engaging each other.
Thank you.
I'll tell you, in cardiac rehab, which I am medically responsible for, we are not lifting the masking mandate. I am actually expecting that UC Davis is going to go back to some of the higher amount of protection in the next week or two if these numbers can, if the trend, the curve that I show you from the last 2 weeks or so that it's going up, if it keeps going up in that slope, I see us in the med center and in the rehab program where I'm responsible. I see us going back to the levels of protection that we had back in November and December of last year. And the other thing is the distance, how do we handle the distance among each other? So I was in the process of trying to get if I could get in a room, everyone vaccinated with a mask, I'm willing to forfeit distance. So everybody washes their hands when they come in. And so we do that already. If everybody wear a mask and everybody's vaccinated, I was willing medically to give up distance so we could still, offer our services to patients who needs our services. So there's a payoff to take that risk. We take the risk of getting rid of the distancing because we believe that patients are going to be better off if they are receiving their rehabilitation services after their heart attack and surgery and whatnot. And so, I was finalizing the paperwork to push that up the ladder when the curves from the last 2 weeks came. So I'm sitting with, I don't know what to do with the paperwork. I have it in my hands and I don't know whether to submit it or not. That's my uncertainty because I no longer know whether if I now break the distance barrier, am I going to still be protecting my patients in cardiac rehab? And as you would imagine, my patients in rehab are, in the scale of risk, they're in the higher risk. So I don't know. It's an uncertain time. I'm going to have to do what I've done many times now in this pandemic. I'm just going to have to sit on my thoughts and wait and see what reality is going to tell me I should be doing.
Right, so we're on the same boat thinking of going back to live action in August, which is just a couple weeks away. And I'm just curious your opinion here, because we could actually impose the distance easier than the masking, probably.
Yeah, I think you're in a better place than we are because you have the space. Right. And so the minimum is 3 feet. The best is 6 feet. If you can keep 6 feet away, even partial masking, which is just your mouth with your nose out and 6 feet, it's better than no mask, I would say. Every little inch in this conversation that you can still do your life, you're trying to return to a normality, which we all agree it's of value. I mean, that's why we're in this program, and that's why you come to the program, because there is value to you. And I would say there is medical value in addition to social and psychological value. There's also medical value to be here. And so with that belief at hand, which I think I have a strong belief, I think it's worth trying to figure out what would be safe for you guys to come together. And so, if you were to ask me, I would say, try to get everyone to keep some sort of mask, or if mask is really bothersome, some sort of little shield. So when you're talking, most of your spit getting stuck in the little shield. So that's an alternative to masking. So even if it's limited, some barrier. So when you're talking, we know one of the very early data we got was that the louder people talk, the more virus was in front of them. So if you keep the distance, now you have to raise your voice to talk to each other, and you have, forfeited some of the value of that. So,
so is your staff doing masking and shielding?
Everybody's doing it. So right now we're doing mask when patients are present. The staff is starting to take their masks down when there are no patients present. And I am
never did this.
Yeah, they're not doing shields. They're not the shields. You see, this is what I mean by UC Davis is probably going to scale us back to that. We were doing eye shields and all that until maybe about a month, 2 months ago or so. And then they took that out. They relaxed that. I think that's going to come back. I think we're going to be back face shields a mask with patients as these numbers continue to rise. So I think in your space, if you have distance, so I wouldn't agree. My opinion would not be that don't mask and don't keep distance because you're all vaccinated. I think that would be ignoring the early signal we're seeing in the curves. But I think you could come together, and again, this is pure opinion, and I understand that, you know, you don't have to agree with my opinion. And but I would say you come together, you got space to keep distance, and you do a, you know, if not a full mask, a partial mask, and then you wash hands. So the concern about the eye shield is that, you know, you can still get some virus through, you know, through the air to get to your eyes. But I personally think it's the hands. It's that you get virus in your hands and then you touch your eyes or your nose, and that the shields just are a reminder not to touch your eyes and your nose. And it's the unconscious touching that we do when there's virus on the surfaces and in your hand. So if you have a really good hand washing and a really good, you know, wash and wipe your equipment, and you just have some sort of reminder not to get anywhere close to your mouth and your eyes, I'm not sure yet that and you're keeping some distance, I'm not sure you need eye shields for people. And you could probably still create as safe as an environment as anyone could create today.
Yeah. And then one more question is about the quality of the mask. So when this first started, it was recommended the N95s, and then I just saw different, you know, people wearing different things. So the N95, are they more protected than the, let's say, the blue mask or the bandanas or whatever?
Yeah, when you do nothing else, meaning you're not distancing and you're not vaccinated and all that, then the mask becomes the strongest thing you can do. And so in the healthcare system, that's why they wear an N95 and respirators and all that, because we have to touch people, we have to take care of them. We didn't have vaccines, and we didn't want the healthcare workers being infected. So that's what the N95 and the higher level is important. But if you can keep distance and you're not among people who are sick, you guys will have a screening at the door. So if anybody doesn't feel well, it's not going to come in the room.
Yeah.
And so you're not in a sick environment. You're not in a hospital environment where you have people who are sick. Even if you're vaccinated, even if you have virus, then you have lower amounts of virus. So this is, you know, one of the factors. So then I don't necessarily think you need an N95 to be in this environment. I think it may, in practical terms, maybe an overkill. But if it gives you the peace of mind, because the other thing is we don't want to get together and be anxious and be like, I'm scared, what's going to happen here? And then our anxiety levels are going up. And then some of the benefit of being back again together in the group kind of goes away if we're all really scared of each other and anxious, because that's not the purpose of being in community again. So,
but so one of the reasons I asked the question, because I've been to the dentist twice, and they only had the blue ones on, and I thought they weren't as good. But you know, I've been to the dentist twice, and you know, the dentist, she's speaking right in front of me. I don't have a mask on, of course, and she's wearing just a little blue one, and there's no distance between us, maybe a foot or so. So I was just wondering.
Yeah, the surgical mask, by the way, surgical masks is what we do. We don't do N95 in our space. N95s are done when people are up in the ICU and they know people have COVID. And, you know, there are lots of more knowns in there than unknowns. We're talking about in a community setting where you're you know, presumably your dentist is vaccinated. And I asked my dentist when I went recently, he was, and you should ask if you don't know. If they're vaccinated, and so presumably you and the dentist are vaccinated, and you have you're not sick, and you have a surgical mask. That is what's recommended, and I don't have any knowledge to believe that you would need that.
Thank you, very good, thank you.
Dr. Lopez, what would your recommendation be for, I'm actually thinking about canceling, but I'm supposed to go to an event. It's an educational event. It'll be a large number of people. It's actually proctoring for State Bar. where people won't necessarily know each other, but they suddenly are requesting the N95s, the distancing. I'm sure they're going to be able to enforce a lot of this. No idea who's vaccinated, of course.
Right.
Um,
So that's what they're managing. They're managing the fact that they don't know who's vaccinated and that the honor system, and I grew up in an honor system from as a kid, and I went to medical school where the honor system in medical school was number one. And so I behave and believe in the honor system. And I can tell you that you can't trust the honor system.
I agree. I agree. That's why
So,
I'm kind of,
yeah.
and assuming that nobody but me is vaccinated.
Right. So the N95 is to manage the fact that you cannot trust the honor system that everybody.
Right, and I'm not sure I can even find one. I have a lot of the blue masks. And then keeping the distance, and I think they're going to require double masking if they don't
Right.
have.
I was going to say the double mask is better than the single mask. It's
Mhm.
probably not as good as an N95. The other issue about N95s is that they have to be fit properly. If they don't fit properly, they're no better than a double mask.
Okay, then I won't try that hard to look for one.
No, a double mask, a well-fitted double mask should be good for you. And distance, you use the tools that you have. There's 4 tools: hand
Well,
wash, mask, and distance. So
Okay, well, that's good, because I was thinking about just canceling. And then I thought, well, with their ability to enforce these, and I know they can, because they can just say you can't come in the door, and I think I'll feel safer with, there's no honor system. They're going to be sure you have a mask and keep your distance and all that.
Right.
So
yeah, I mean, and if you go into place and in real time, people are simply not able to keep their distance, then just keep your options so you can just leave and like make sure you have a ride you can call and stuff like that.
right.
So you're not stuck somewhere for 6 hours where no one is keeping distance, and
Yeah. And
just have a backup plan.
I hated to cancel at the last minute, but then these new restrictions came at the last minute. I'm sure they're keeping up on the data that you've just reviewed. So they've had to, add
Yeah.
layers of protection.
You should anticipate that slowly every activity or venue you may get involved with in the next few weeks to months will have some probably additional recommendations. I just can't see how long we're going to hold you can still gather in groups and no mask, which are 2 to 3 week old recommendations that haven't been updated. I think I looked in CDC website before this, and I think it was June 16th, the last update that I saw, July 16th, I'm sorry. So that's about a week ago. I just don't know that they're saying that they're going to change them when the data supports that they need to be changed. And what I'm saying to you is the noise in the data is going in the direction that the data sooner rather than later.
Yeah.
Convincing.
Is this a good place to ask again about a booster shot?
Yeah, booster shots. Yeah, no, that's great. So booster shots.
What do you, I don't even know if they're available in my case.
They're not available. There's a little battle going on between the pharmaceutical company and the CDC and the FDA, and so there was a little bit of a shouting match among the top dogs in that fight. And at some point, the pharmaceutical company was saying, "Hey, we're ready to give the booster shots," and the CDC said, "We'll let you know when we think we need a booster shot. We don't think we need a booster shot yet." And so there's a little bit of the pharmaceutical companies are ready, and the health authorities are not ready to pull on that trigger because they're not convinced yet that they're needed. I think it is the most obvious issue right now is the insufficient vaccination of the first shot. It is not obvious yet that we have a big problem with people getting sick in such a way that you then trigger the need of a booster, which becomes a widespread. So it's basically I think what is 190 million people immunized in the United States is starting when we can yet immunize the other. It would be 100 million that are left or so, or it's 330, right? So
now, do those include the ones that refuse to be?
Right. So you still got to get still over 100 million people that are not vaccinated, and so they're trying to put every effort to get that done instead of diverting at this point, so this is the public health decision they're trying to make. What's the value of diverting efforts now to start giving boosters? How much are we going to gain from that versus trying to still put every effort we have into getting that other 100 million people that are reluctant or just haven't got the message yet vaccinated? And so at this point, the energy of doing one versus the other continues to favor the stay focused on the biggest value, which is to get everyone the first set of shots. So that's why public health wise, there hasn't been any recommendations for booster. But I think as this data, as this uptick keeps going up, if we start seeing more death and more hospitalizations of people who were previously vaccinated, those numbers start getting larger, which at this point are really small, by the way. If they start getting larger, then I think they'll be ready to then go ahead and recommend boosters in the near future.
They
But
just
the
have
data
to-
is not there yet.
Right. Thank you.
You're welcome.
So can you share your opinion, your personal opinion about the Olympics and, you know, baseball games and big activities that are basically really proud that they're back at 100% capacity?
Yeah, I wouldn't go to anywhere. I am not comfortable today going anywhere where it's 100% of what it was pre-COVID. I've gone to the movies, and I went with the family to the movies, and we said if the theater is even 50% full, we're going home. And it was only 15% full, so we were very comfortable. We went to the movies. But what do we get? We did that, and the kids got together with friends, and we now have colds. Everybody at home has a cold. They're all COVID negative, but everybody got the sniffles and the sore throat. And so guess what? Guess what's coming? It's real life. We're going back to real life. Real life was one where we had colds and regular, other infections that are no coronavirus. So that's what I'm personally experiencing. So I'm going to wear a mask. I got comfortable wearing my mask. So I'm probably going to wear my mask for a long time in public, because I like the idea of not getting colds. And if it's practically I need to not wear a mask and I'm comfortable in the environment, I can keep distance, I know where everyone else is on their vaccination, I'll take them off very, very casually. But most of the time in public, I'll personally will probably be wearing a mask, just because, not just for coronavirus, but also for all the other viruses and colds that are out there.
Thinking of these group activities that Linda brought up, I watched the basketball finals the other night, and I don't know if any of you saw them or saw the crowds outside in Milwaukee, but it was like, I don't know how many thousands and thousands of people just jammed together, cheering and yelling. And I thought, oh my gosh, Dr. Fauci must be just having a heart attack watching that. I mean, it was just, I couldn't believe it. And I thought somebody should do a study. I'm sure they will. How many, follow up, how many people becomes ill after that? Because it was just, I don't know. I just couldn't believe it.
Yeah, it's hard.
Yeah.
Javier in the chat about children. Do you think kids are more, kids are less vaccinated than adults, right?
So yeah, so kids under 12 are not vaccinated at all. Kids from 12 to 16 are being vaccinated. And so kids in general are fairly spare when you look at large populations, but there are some kids who are getting sick, and unfortunately they get this very difficult to understand multi-system inflammatory disease condition, which is very devastating. It affects every organ in the body, and it's relatively rare, but it is sufficient to be a big dent. It's not a rare case here and there. There are enough cases to be a significant concern for the kids. The problem with kids is, can you mask them? The idea, everybody's talking about going back to school again. Everybody wants to go back to school, and no one is yet talking about changing that. So I think everybody's going to be in school probably in September. If there was a way for them to be masked, especially the under 12, and that's what I'm talking about right now, I think it'll be better. Not so much for themselves, although there is an impact to them. is also they're gonna, like every other coal, they're gonna be the ones bringing it back home. So they're gonna become the portal exchange when the school's back on. And you know, I don't know how to handle that. I have kids and I have parents, so I got the whole, you know, grandparent access. And we don't know yet exactly how we're gonna handle that, but before we vaccinated my son, he's 13 now, so you know, the pandemic began, and then we were able to vaccinate him, but he wasn't, because he wasn't 13 yet. He wasn't old enough. I'm sorry, he wasn't available for him yet, but he was available for everyone else. He wore mask. He wore the mask when we went to visit the grandparents. He stayed on the, you know, he stayed in the peripheral of the room, we kept the window open, you know, so we took some measures at home until he was vaccinated. And now that he's vaccinated, then we are, when we visit the grandparents, we are, you know, following the rules, which is when everybody in the home is vaccinated, then you can go back to a normal kind of environment when you know for sure that everyone's vaccinated.
My personal, I don't think kids have as big an issue wearing a mask as adults do. They just go,
Yeah.
right?
Right. If you teach them, that's the key. The adults have to actually make it normal, make it fun, make it like it's the thing to do. Oh, let's draw some figures. Let's make some colors. Let's have fun with this. And you're right. Kids probably will have as little, you know, like kids are very, you know, they're very amenable, especially if they can see some value to them, which is fun,
Yeah.
or love and attention, which is the things, you know, they're not hungry. They'll probably play along, you know, some game with mask on, and before we know it, they'll be happy to be with a mask. But it takes the parents and the teachers and the adults to get beyond their issues to then teach your kids to wear the mask.
Yeah.
So you're right. This is fun, guys. So I enjoy always as usually to do this, and I hope there was some information that was new to you, and some of this discussion helps lower the anxiety and help you make plans for the activities personally and in the program.
No. Definitely very, very useful. Thank you so much for joining us.
Thank you so much. As usual, you were very informative and gave us lots of things to think about.
Yeah, thank you.
You're
Thank
welcome.
Thank
Enjoy-
you.
You're welcome. Enjoy your weekend, and we'll see you hopefully next month with Dr. Shakari.
Yeah, that'd be great. Thank you.
Thanks, Doc. Good to see you.
You're welcome. Oh, hey, Wes. Good to hear your voice.
Yeah, we're still alive.
Yeah, no, that's great. It's good to hear your voice.
He's in North
Thanks for the presentation. It was great.
Oh, you're welcome. I see Dave Clark there.
Yeah, he's never hard. He rarely misses.
Yeah, good to see you.
Bye all. Thank you.
Thank you, Marianne.
Bye-bye.
See ya.
I saw your brother.
Dave has a brother?
Yeah, Dave has a brother. So
You're
oh,
muted.
you're muted.
David, you're muted. Donald, you're muted.
Or yeah.
There you go.
Yeah, I do have a brother. He's now a patient of Dr. Lopez's, but I'm going to make him look real bad because he hasn't gotten with the program yet. So we're working on it.
Yeah, no, I mean, we all have our own time, our own speed to things. So,
Right.
But he chatted with me. We had a good conversation. So
Yeah, he liked you a lot. So
that's a good place to start. So
Javier, is prevention forward moving forward anymore, or are you still on hold?
no, I'll tell you my good news. My good news for the week is 2 of my grants got funded. I'll tell you my bad news for the week. 2 of my grants got funded. So Prevention Forward got funded, and now I have 2 other grants funded. So now I'm going to be